Okay, we are ready. I'm going to ask everyone to mute until you are asked to come forward, please. Well, good afternoon, everyone. We want to thank you for coming to the BFSA webinar on medical disparities in healthcare. We have our distinguished guest, Dr. Michele K. Evans, and we also have Dr. Sharlene Newman from the University of Alabama, who's going to moderate. I'm going to introduce Dr. Newman, who will then introduce Dr. Evans, and we will begin the webinar. Dr. Newman is the Executive Director of the Alabama Life Research Institute, one of the 4 research institutes at the University of Alabama. She's a professor in the Department of Psychology, an adjunct professor in electrical and computer engineering at the UA. She's also an interim director of the Alabama Research Institute on Aging. Prior to coming to the UA, Dr. Newman was the Herman B. Wells Professor in the Department of Psychological and Brain Sciences at the University of Indiana, and she served as director of the program in neuroscience, director of imaging research facility, and associate vice provost for undergraduate education. Her research focuses on understanding human neurocognitive function with the use of magnetic resonance imaging, MRI. Please welcome Dr. Newman.
Hello, it's my pleasure to introduce Dr. Michele Evans. Dr. Evans is an internist and medical oncologist who serves as Deputy Scientific Director at the National Institute on Aging at NIH, as well as the Training Director for the NIA Intramural Research Program. She's trained as a physician scientist who conducts epidemiological clinical research and health disparities and basic bench research on the biology of health disparities and minority aging. Dr. Evans is the PI on the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study, which provides a cohort for translational research studies to facilitate investigation of health disparities in terms of a medical biologic phenotype that may be amenable to dissection by bench scientists examining the molecular aspects of aging, disease, and disability. So it sounds like a mouthful, but I'm excited to hear Dr. Evans talk. And so, Dr. Evans, you have the floor.
Well, thank you very much, Dr. Newman. I would also like to thank Mr. Jackson, President of the University of Alabama Black Faculty and Staff Association, for the very kind invitation to present our work today. I'm really just honored by your invitation. As I think I told Chad in an earlier email, I have actually visited the campus many years ago as a speaker for the RICMAR program that was present at that time at the medical school. So today what I hope to do is sort of just talk to you about my work in general. I'll be happy to take any questions that arise from it. As you all know, health disparities research is a broad and multifaceted field that includes basic, applied, clinical, behavioral, as well as translational research. Today, I will try to share a bit of our disciplinary approach that's targeted towards understanding the biologic transductions pathways through which social determinants of health lead to disparate health outcomes. We can describe health disparities as differences in health that occur related to the various factors outlined here on the slide in blue. Although there is some evidence that health disparities are narrowing in selected spheres, in the United States, health disparities that are associated with race, ethnicity, or socioeconomic status remain widespread. There remain persistent significant gaps in all-cause mortality, cause-specific mortality, and life expectancy gaps as evidenced by these data from the National Center of Health Statistics that show a 14, almost 15-year age gap between African-American males and Hispanic females, and almost an 8-year gap between African-American males and Hispanic males. But these are national statistics. What can I tell you about Baltimore? We study health disparities in the city of Baltimore, our nation's 30th largest city, with a population of somewhere around 620,000, 62% of which are African American. Many live in poverty and are burdened by poor health and early mortality. This differential risk is exemplified in life expectancy statistics at birth in Baltimore City, where we see that life expectancy in Baltimore is comparable to what we find in Azerbaijan, Syria, or Vietnam. In the red neighborhoods in the graph, life expectancy is comparable to that seen in Yemen or Papua New Guinea. In the green areas of the city, life expectancy in some cases exceeds US life expectancy at birth. So we often talk about these mechanisms of health disparities, and they're incredibly difficult to dissect. Clearly, the root causes are multifactorial, as illustrated in these two graphical representations, and include social as well as political determinants of health that might include poverty, poor access to care, stress, racism, as well as class and gender inequality that across the lifespan. So the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study is an interdisciplinary, community-based, longitudinal epidemiologic study of age-associated health disparities among a socioeconomically diverse cohort of African Americans and whites who reside in the city of Baltimore. We set out to try and understand how race and SES influence health disparities independently or contextually in terms of the environment, biologic or psychosocial factors, as well as to understand how they influence the severity of age-associated disease and rates of aging and functional decline. And from the biologic standpoint, to try and understand what mechanisms were important and were there any relevant biomarkers of health disparities to allow us to determine early who was at greatest risk of a poor health outcome. So the study has many interdisciplinary research domains to keep it comparable to other nationally diverse longitudinal cohorts. We not only had scientific objectives, but we also built in operational goals and objectives that included enhancing training opportunities in epidemiology and health disparities for students, as well as to enhance the participation of minority investigators and students in clinical research, and also to develop effective community-based methods to help in recruiting and retaining minority and socioeconomically diverse participants in clinical research. So the overall study design for HANDLES is that HANDLES is an area probability sample of the entire city of Baltimore based on the 2000 census. Our survey statisticians and demographers identified 13 census segments that, based on the 2000 census, would likely yield representative distributions of the city of Baltimore and have enough individuals to fill our sampling frame, which was African American and whites, who were between the ages of 30 and 64, who were above or below the 125% poverty line as designated by the HHS Federal Poverty Guidelines for 2004. The goal was to recruit somewhere between 3,500 and 4,000 individuals who we would follow as a fixed cohort, trying to understand the forces that led to poor health outcomes in the population. And the way we would do this was to build mobile medical research vehicles, which we use as community-based research platforms. So in the baseline phase of the study, which started in 2004, we were able to recruit over 3,700 individuals who we continue to follow to this day. The pandemic certainly has slowed our progress. We had to shut the study down for a while. Now we're working with participants in terms of providing asymptomatic and symptomatic COVID testing, as well as trying to increase the ability for them to obtain vaccines and also studying the effects of the pandemic. So our mechanisms of health disparity model considers these social determinants of health here as agents that work through biologic transduction factors that ultimately result in the accelerated aging phenotype or weathering that leads to health disparities and shortened lifespan. And there are many biologic factors at play here, including genetics, inflammation, oxidative DNA damage, epigenomics, gene expression, as well as alterations in the immune response. So I guess we're trying to understand what are the outcomes when these social determinants of health get under the skin, when poverty or class inequality or access to care get under the skin. So one of the things we decided to study was perceived discrimination. And we studied that because it's a psychological stressor that has been associated with hypertension and obesity, as well as with worse self-reported health. In a way, we were considering perceived discrimination perhaps as yet another vital sign to consider in evaluating a patient's health. So we asked our participants a number of questions using validated measures, things that included questions like, overall, how much harder has your life been because of discrimination? Overall, how much has discrimination interfered with your life? We used the racial discrimination measure developed by Nancy Krieger, where we are able to ascertain whether respondents ever experienced racial discrimination at school, when getting a job, at work, when getting housing, when getting medical care, from police, or in the courts. So we initially looked at perceived discrimination in the context of renal function. And we did this because, as you all know, African Americans are 4 times as likely to develop renal disease than other subpopulations. And in fact, make up the largest percentage of those who go on to require renal replacement therapy because they develop end-stage renal disease. We initially looked at chronic kidney disease and found that poverty, which is also a stressor, was associated with a greater prevalence of chronic kidney disease in African Americans, but not in whites. So we decided to look at the baseline renal function of an early subset of our population in the context of their self-reported perceived racial and gender discrimination, and then longitudinally follow them up over 3 to 5 years to look at changes in their estimated glomerular filtration rate, which is what we use as a measurement of their renal function. And what we found is that over this time period, perceived racial and gender discrimination was associated with a decline in renal function among African-American women. We also found that when we looked at women overall, that perceived gender discrimination was associated with a lower baseline estimated glomerular filtration rate. In white women who reported a high experience of discrimination, this was also associated with a lower baseline measure of renal function. So our work, we feel, certainly suggests that perceived discrimination deserves further investigation as a psychosocial risk factor for renal disease. We also wanted to understand the relationship between discrimination stress and brain health. As you all know, African Americans have a disproportionate burden of poor clinical health outcomes. African Americans have a greater risk for developing dementia compared to whites, compared to Asians, and also compared to Hispanics. So we wanted to look at the relationship between lifetime discrimination burden and racial discrimination with age and white matter lesion volume. Now, white matter lesions are focal areas of demyelinated cells. So this is a normal MRI. This is an abnormal MRI and you can see this hyperintense region here. These are white matter lesions, which are non-specific degenerative injuries that are in some cases consisted with cerebral small vessel disease. They're a predictor of poor brain health in the future, poor cognition and dementia risk. So in the African Americans, and a small segment of African Americans in our population, we did MRIs and looked at the results in the context of their reported discrimination burden. And what we found was not 100% what we expected. While there was a linkage of discrimination to a subclinical brain endpoint, white matter lesion volume, we found that it was a nonlinear association as a function of age. We had predicted that higher levels of either lifetime burden of discrimination or racial discrimination would lead to increases in white matter lesion volume. So that part of our hypothesis was correct. Conversely, though, among younger African Americans, and remember, we started at age 30, so we have many, at this time, we had many who were between 30 and 40 years old. Among these younger African Americans, greater exposure to discrimination was associated with less brain pathology. So our take on this is that perhaps there are different coping mechanisms or strategies for dealing with discrimination between younger and older cohorts, or that the younger cohort just has not reached the age where the biological impact of discrimination may be felt. So we think that this data certainly, again, suggests that racial discrimination and/or lifetime burden of discrimination may in fact be related in some way to the disproportionate burden of poor brain health that is observed among African Americans. Now, we also examined discrimination in the context of cardiovascular disease because of the significant disparities in African Americans with cardiovascular disease, but also because participants actually come to their mobile medical research vehicle appointments exhibiting the most dire complication of cardiovascular disease, the acute MI. This is the abnormal MI, as you can see here, these peak T waves, of an individual who came in just saying he was tired and he was very frustrated with things that were going on at his job. This was his EKG. And this is not the only abnormal EKG consistent with acute MI that we have seen on people who were walking and talking and just coming in. They don't have chest pain. They might be a little angry about something, but they're not exhibiting the normal characteristics that you would expect. So we have to have a very high level of suspicion. So what we wanted to do was to try to identify these people earlier on at a subclinical level. And so we decided to measure the thickness of the carotid artery intermedial thickness, which is measuring the wall of the inferior carotid artery. And so we were able to measure this using high resolution B-mode ultrasonography. And we took this in the context of looking at discrimination and depressive symptomatology, because we know from the work of other investigators that discrimination and depressive symptomatology is related in African-American men. And we know that in primary care settings, as many as 50% of African-American women may have depressive symptoms. So we did this high resolution B-mode ultrasonography on both African-Americans and whites in the Handel study, and found that in African-Americans, higher lifetime burden of discrimination and greater depressive symptoms were related to a thicker carotid intermedial thickness. And when we did the same analysis in whites, looking at the thickness of the vessel wall and reports of discrimination, there were no significant associations, which certainly suggests that in this case, discrimination may play a role in the risk for cardiovascular disease among African Americans. And we also tried to take it down to the cellular level. Could discrimination relate to an aging biomarker like the telomere? The telomeres are these little red caps here at the ends of the chromosomes, or here, these little yellow dots that you see. They're short nucleotide sequences at the end of our linear chromosomes, and their main job is to protect genetic information and prevent genomic instability. Now, long telomeres are good. They're related to normal health and longevity. Short telomeres are associated with age-associated diseases and reduced longevity. Now, there are biological factors that drive telomere shortening, like cell division and also age, the age of the organism, as well as DNA damage and inflammation. But there are also environmental factors like stress that can cause telomere shortening. So we investigated the relationship between discrimination and telomere length in Handel's using quantitative polymerase chain reaction and Southern blots. And what we found was that, number one, among African American women had shorter telomeres than men. Women who reported a greater lifetime burden of discrimination, racial discrimination, or gender discrimination also had very short telomeres. Now, when we looked at the higher income African Americans, the higher SES African Americans, they had greater lifetime burden of racial discrimination as well as shorter telomeres. And even in the younger adults, we found that if they reported greater exposure to multiple sources of discrimination, they also had shorter telomeres. Now, whites did and do report racial discrimination. In white women, it made no difference in their telomere length. In white men, it was a mixed response. Younger white men who reported discrimination had shorter telomeres. Older white men who reported discrimination had longer telomeres. So it's a little bit of a mixed response, but we do feel that the data supports that discrimination may contribute to the age-accelerated phenotype that's associated with health disparities, particularly among African Americans. So, you know, it's possible that discrimination could be considered as a new vital sign, and that physicians and psychologists should be considering the direct and indirect the measurable and unmeasurable effects of discrimination and racism on health. And also, we all need to recognize, there are 4 dimensions of racism. We have, in our work, looked at really interpersonal reports of racism. Some of our work looks at institutional, but we really have not, I think, dissected structural versus internalized versus institutionalized. This is a very complex relationship, which I feel is a very rich area of research, not only in my own studies, but I think also at the field level is something that we need to do more work to really understand these relationships, because they have been critical in the pandemic. I don't have to recount for you what's happened with COVID in the nation. I can just point to you that in our study, each of the neighborhoods in our study had among the highest levels of COVID infection and COVID mortality in the city of Baltimore. And I don't have to recount to you that it's minority populations who are more than likely to have died from the infection, not just African Americans, but Native Hawaiians, Alaska Natives, as well as Hispanics. When we look at this, Indigenous Americans have had the highest actual COVID-19 mortality rates overall, 2.8 times as high as Asians. But these are statistically very difficult. 1 in 595 Indigenous Americans have died. 1 in 735 African Americans have died. Those statistics, are just very difficult for us to accept. And it has consequence, because we talked about earlier in the talk about life expectancy. Well, COVID-19 has already had an effect of life expectancy. The recent National Center for Health Statistics report reveals a disproportionate decline in US life expectancy for the first half of 2020, January to June 2020. African Americans lost 2.7 years of life expectancy. Latinx populations lost 1.9 years of life expectancy, making this the lowest life expectancy estimate for African Americans since 2001. So we have lost ground. Now, these are just 6-month statistics, but that's something for us to consider in the context of the disproportionate nature of the pandemic. So what drives COVID-19 health disparities? The same things that I've been studying. Income and social status, social support networks, education, employment, social environments, health practices, structural racism, as well as social vulnerability at the community level. So when I talk about social vulnerability at the community level, what am I talking about? Well, it's how do communities respond to emergent hazardous events, tornadoes, chemical spills, or a disease outbreak. The social determinants of health, such as poverty, lack of access to transportation, crowded housing conditions, weakens a community's ability to bounce back and prevent human suffering. So these are the factors that are known as social vulnerability. Now, the CDC, working with its Agency for Toxic Substances and Disease Registry, has created databases that help emergency response planners and public health officials identify which communities are vulnerable. So the CDC uses US Census data, much as we use census data to create the Handles cohort. And they look at these census tracts on 15 social factors, such as poverty, lack of vehicle access, crowded housing, and then groups them into related themes, such as SES, household composition, housing and transportation, race, ethnicity, and language. And then Each track receives a ranking on each of the 4 themes, as well as an overall ranking. So when you look at this in terms of the United States overall, you can see that there are different levels of social vulnerability per this CDC Social Vulnerability Index. The light yellow means that there's low social vulnerability. Deep blue is high social vulnerability. So many places throughout the South, even on the West Coast, there are high levels of social vulnerability. So in Baltimore, as you might imagine from what I told you about the life expectancy statistics, Baltimore has a high overall SVI or social vulnerability index. 0 means you have the lowest vulnerability. 1 is the highest on the score created by CDC. Baltimore comes in at 0.8364. And then when you look at Tuscaloosa, for the zip codes that are listed for the city of Tuscaloosa, there's a wide variance. So in some neighborhoods, if you live in the 35406 zip code, there's a very low social vulnerability. You know, probably the house prices here are high. These are nice neighborhoods that have resilience and can take care of themselves in a negative, hazardous situation. But there are areas in Tuscaloosa that also have a very high social vulnerability, as high or even higher than what we see in Baltimore. And this plays into the vulnerability of the nation to the coronavirus. So just where we saw all of the high blue in the previous slide, here when we are talking about vulnerability to the coronavirus, this is in orange. So this lets you know where the risk has been greatest. So in this sense, this tool has been very useful. And in fact, the state health officer, Dr. Scott Harris, has begun to do the allocation for vaccines in the state of Alabama using this vulnerability impact to make sure that they can identify communities that have been disproportionately impacted by COVID-19 and to try to get vaccines to those portions of your state. And many other states are also doing this matching. And in terms of vaccines, although I think perhaps we're beginning to turn the corner, as you can imagine, those who needed to get vaccinated were not always the ones who were getting vaccinated initially. You know, in my own state of Maryland, initially, we had a very low percentage of those who needed to be vaccinated getting vaccinated, even in the context of the percentage of African Americans in the state. Back in January, 1.2% of white Pennsylvanians had been vaccinated, as compared to 0.3% of Black Pennsylvanians. And many more than 0.3% of Pennsylvanians turn out to be African American. So there was certainly a mismatch in many of the states, and some states are still grappling with that. Although it's beginning to improve, we still, and this is data that's from March 9th, that is from the APM Research Lab, that still shows African Americans and Latinos are still lagging behind whites, Asians, and indigenous populations in receiving the vaccine. Now, there's lots of discussion about what are the things that are driving the intent not to pursue the COVID-19 vaccine. And this is a paper from this year that showed that the intent to refuse vaccination was higher for African Americans, for women, for conservatives, and for individuals who voted or intended to vote for President Trump in 2020. Women were actually much more likely not to pursue the vaccine. So it was not African Americans who had the highest levels of vaccine hesitancy. But political affiliation certainly did create some vaccine hesitancy. However, when you look at African Americans and their, I think, consideration of vaccine, we have a very well-founded history on why we may not want to be the first to get vaccinated. And that's because of what happens to us in medical establishments every day, but also what has happened to us historically. And so there's a very solid founding on the concerns that African Americans raise when considering vaccination. And it's not just race, sex, or political stance that influences vaccine hesitancy. It's also where you live. In this work by the Kaiser Family Foundation, rural individuals were not as worried about getting sick. They thought that the severity may be somewhat exaggerated. And so, you know, it's really more of a personal choice and not a community choice for them to get vaccinated. So where you live also influences perhaps how you feel about getting vaccinated. And many people had very valid reasons. You know, people talk about vaccine hesitancy as though, well, I can't even understand why people would be hesitant. Well, yeah, they're concerned about possible side effects. That's a well-founded concern. They don't trust the COVID-19 vaccines. They don't trust the government. Well, those are things that I think we all have to look at our own life experience and make appropriate judgments for. And others plan to wait to see if it's safe. And I think some of the people who are now deciding to get vaccinated have had others in their lives who have been vaccinated and now feel that perhaps it is safe. So I think the one thing that we've sort of learned through this pandemic is that we really are living with the results of a cascading conglomeration of public policy that is just broken. We've underfunded public health. We've undermined equitable healthcare access. We've underfunded community health centers, as well as economically, educationally, and judicially marginalized minorities. And that's how we have wound up with this deadly triad of health disparities, health inequity, and unequal healthcare access that we can quantify in a daily body count. So, you know, we really have to, I think about where we are now historically in really understanding what's driving these outcomes. In his excellent book, Daniel Dawes asks us to focus on the political determinants of health and to ask ourselves, are all trees in the orchard being equally nurtured? And I think this diagram here certainly shows that they're not. You know, Thomas Jefferson said that the care of human life and happiness is the first and only legitimate object of good government. I think we have to recognize that the primary factors driving poor health outcomes are in many cases the results of political determinants of health. Political actions such as the compromise on slavery at the nation's founding, the failure to sustain the gains of the Reconstruction, the institution of Jim Crow laws that legalized systemic racism and white supremacy, the inability to respect Indigenous Americans' rightful claim to their native land, all set the stage for these social determinants of health that many of us study. And we believe that they promote health inequities and differential health outcomes. You know, Dawes would argue that it's the political determinants that lead to the social determinants of health that we study, and we need to be studying them in a conjoined fashion to try and intervene on them. Now, one person who intervened on them, or one group of people who intervened on them, is H. Jack Geiger, Count Gibson, and John W. Hatch. This is H. Jack Geiger, and this is John W. Hatch, who worked to develop the community health center model in the United States, founding the nation's first community health centers that tried to address this, because their concept of health was to make social change, to build institutions that make social change and keep it going, calling it community health action. And these community health centers, which we have underfunded, really are the backbone of providing care to millions of low-income and minority patients. Geiger and Hatch and Count also wanted doctors to use their expertise and moral authority, not just to treat illness, but to change the conditions that cause poor health in the first place: poverty, hunger, discrimination, joblessness, as well as lack of education. So we all find ourselves trying to figure out, well, how do we try to fix this? How do we address this moment? Well, I think as educators and as physicians, as practitioners, we have to recognize the difference between equality and equity. This disparity in health and education and economic opportunity challenges clinicians and educators to recognize that equal treatment may not be enough to close the gap or correct the systemic disadvantage of patients and students in our care. We have to recognize the special needs and personalized targeting of those needs in the provision of medical care and/or education, and the provision of the ancillary support that provides equal opportunities, equitable opportunities for health and education equity. And this is, it's not an easy problem, and it becomes even more difficult in the context of the steps that we need to go forward. And one of them is to recognize and strategically prepare for the demographic majority-minority shift. By 2060, only 43% of the US population will be white. So we will, by 2060, have more people who are members of a minority group than we have ever had. And this is even more important when we're looking at those who are under age 18. We as a nation are not completely prepared for these upcoming demographic shifts. There's been much more attention paid to the aging of the US population. By 2030, 1 in 5 Americans will be 65 and older. And we've talked about how this is going to influence healthcare needs and health economics. The challenge ahead is for us to, as physicians, prepare better clinical management for chronic disease among minority populations, as well as more prevention strategies that work. But we must also prepare for the unique educational challenges that will be present because of this shift, because this will directly influence overall life expectancy. In this work that I think just got published this month from Ann Case and Angus Deaton, it shows that you will have greater life expectancy with a BA degree than without. So this is the whole population. A third of people with a BA will live longer and more prosperously. And those without a BA will have declining life expectancy and rising mortality. And when we look at this in the context of African Americans, there is a mortality turn down for those without a BA. So here are African American men with no BA and African American women with no bachelor's degree. When we look at African American men with a bachelor's degree, you can see that their life expectancy rises, still not quite what white men have, but certainly comes up dramatically. and is well above white men with no bachelor's degree. And the same is certainly true for women, in that we see a decrease in the gap between whites and Blacks with BAs. So this influence of education and educational attainment is critically important for all of us to recognize. So our roles as healers, as educators, as ethicists and reformers, and also as activists, we have to think in our heads, how can we all enhance the ability of academic institutions, academic medical centers to catalyze social change and intervene on the social determinants of health? You know, as a physician, of course, I'm trying to fulfill the medical contract to society to use finite resources to balance delivery of care, to be professionally competent and have honesty and integrity, and also to respect persons, to be beneficent, and also to make sure that justice is fundamental in the equitable healthcare and healthcare access. But I think we all, at the university level, at the medical center level, have to improve bachelor's degree attainment among African Americans, especially among African American men. And we all together must work to dismantle systemic, institutional, and interpersonal racism by trying to improve communication and interaction across the difference. Because these multiple forms of racism impede educational opportunities, and then that leads to the lack of representativeness we see among undergraduates at certain institutions, but particularly among actively practicing physicians and academic faculty across academic institutions throughout the nation. Now, we have tried our best to live up to our operational goals by trying to develop and put forth a diverse cadre of health disparities researchers. A lot of the renal work that we talked about today was done by Deirdre Cruz and Raquel Charles, who I have been working with since they were third-year residents in internal medicine at Hopkins. Deirdre is now a full professor. Raquel is now an associate professor. And then some of our own postdocs whose work I didn't have a chance to talk about today. Marcellus Merritt was a postdoc in our laboratory. He's now a tenured associate professor. Kumar has just left the nest and he's now an assistant professor up at Temple. Alyssa Gamaldo and Angelina Sutton, I didn't have a chance to talk about their work today, but they're now tenured professors at their respective institutions. Danielle Beatty-Moody is now an associate tenured professor at the University of Maryland, Baltimore County. She came to us as a young tenure track wanting to work on discrimination. And the work I've talked to you today about largely is part of her research portfolio. And in addition, we have some basic scientists at the bench because we have to have scientists at all levels who are well-trained in understanding health disparities, social and political determinants of health. And this crop of young ones have come through my lab and are now preparing for careers as MD PhDs in a number of different fields, but with the contextualization of understanding health disparities. And I'm just very fortunate to have had them come through my laboratory. This is my co-principal investigator, Dr. Alan Zonderman, and we speak across the divide. This has been our conjoined intellectual project because we feel it's important that these problems that I've addressed to you today are everyone's problem. It's not just the Black scientist, the Black physician, the Black educator's problem. It is all of our problems to address these issues to have a more equitable society. And we've worked very hard to make sure that our research team looks like America. And also that we give women very prominent roles. May Bay Dune as one of our staff scientists, was very important in the renal discrimination project. Nicole Norenhouten has worked with many of our students who are pursuing basic science in the context of health disparities. And our chief physician is Dr. Eng.ua.edu, who has worked so closely with meeting our participants where they are and supporting their healthy journey. She is sometimes the first person they call when they're sick. And we said, but we're your research physicians. They tell her, no, you're my doctor, because you tell me what I need to tell my doctor to make sure he listens to me adequately. So I would leave you with this, that the struggle for health equity is real, and an academic institution is the perfect opportunity for us to really advocate, to serve, and to lead, moving towards what we hope is the ultimate goal of our country, to be one country sharing one destiny, which were the words that were sewn into Abraham Lincoln's coat on the day he was assassinated. So I'll end there and take any questions. Thank you very much.
Thank you so much for that wonderful talk. I think there are lots of questions that are running through everyone's mind. And if you're on the Zoom call, you can post your questions in the chat. I'll be monitoring them. But we'll get started with some of the questions that were submitted previously. So I think you just mentioned so much that sort of has me thinking, and I have lots of things I want to ask you as well. And I think I'll start from like what you ended on, right? So, and this is one of the, I think, related to one of the questions in the chat, and that is the physician in your group and people sort of saying, you're my physician. I need you to tell me what to tell my physician so that he listens to me, right? And so a question that has come up is, one, do you think things have changed in the last 10, 20, 30 years in terms of the way physicians interact with their patients? Do you think it's gotten better or worse? And what should we be doing to make sure our physicians listen to us, both at the personal, community, or maybe some organization level? Like, what can we do to make them listen?
Yeah, I mean, I do think there have been some changes. I think the Affordable Care Act did begin to change some physicians' viewpoints of what they needed to do in the visit to have it be considered a successful and complete visit. I think they tended to listen more to their patients. But I think what we have tried to do throughout our interactions with our participants is to make them an educated healthcare consumer. You know, you need to go in with your questions written out, because it's gonna be a quick visit. They are gonna try to get you out there as quickly as possible. So when they say, how are you doing? I have these 4 questions for you today. Boom, 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 written down. And then you're taking notes, or you've brought somebody with you to take notes. Because physicians tend to respond, oh, she's writing stuff down. Well, I need to make sure I'm more complete. And, you know, although they want to rush you out, they will try to give a better answer. And, you know, physicians are asked sometimes to see 25 patients in a morning session. That's too many. There's no way you can give the attention that you need to really kind of get to the heart of the matter of why that patient is there in just these very, very quick visits. But we as patients have to combat that and make sure that we get our time and maybe a little bit more time. And that's what we try to explain to our participants. So we will, if we try to kind of get them prepped and send them notes, like after they get a printout of our visit, and we will sometime write at the end of a computer printout, these are the 3 questions you need to ask when you take this to your doctor. And then sometimes they give us permission to just send the whole packet to their physicians. But what's happened with the sort of the shrinking of the Affordable Care Act Many fewer now have physicians. Blood pressures are starting to go back up. So lots, so there have been lots of issues with the instability of the Affordable Care Act and the contraction of care. So hopefully with the new administration, we'll be able to fix some of those problems.
Yeah, and I think one thing that you said in the answer is something that we can maybe all think about, and that is you give back. One of the ways you're giving back to the community is giving them a list of questions to ask, right?
Mm-hmm.
So when we're thinking about our own research, how can we help educate our community and give them?
And we have a newsletter. I mean, and through the pandemic, the newsletter now is monthly. Usually it was quarterly.
Mm-hmm.
It's essentially been almost monthly because there's been, something that we've had to talk about. Okay, if you're food insecure, here are the places in Baltimore. Here are recipes to stretch food. We have participants coming in for COVID testing. Usually we would have them, give them a breakfast, give them some lunch. Now we give them groceries because we know that food insecurity exists. So we're always trying to think of ways that this study benefits them. Yes, we're doing research, but it has got to be equally managed so that really the benefit to the participant may be higher than what you get out of the research. Because in vulnerable populations, that's the approach you just need to take. You're going to need to spend more money because you're going to give that benefit.
Yeah. So I think another question that's come up is you've made sure you have a diverse research team, right? So how important is that, do you think that diversity is, and how much? So we hear about on the science side, because I'm a scientist, about the pipeline issue. You seem to not have a problem finding your diverse people to work in your lab.
Yeah, it's not easy. No, it's not easy. I'm just here to tell you. That's why I put my slide up, because I just love my slide. But I mean, it's a hard fought war. And I will take people in my labs with a 2.7. Okay, come on, baby, we can work with that. Understanding potential and reading potential is key. I am not going to be looking at your transcript and talking about your mama. I'm going to say, yeah, organic, that was no friend to me either. So come on up in here. If I could do it, we can get over that. I've learned a few things in my day. And see, that's some of what, because the potential is there. We know that in STEM, they're not teaching for the test. It's a bullying experience, even for those who are most adept. I had the Ivy League experience, which is the ultimate bullying experience, I think, and who's smart and who's not, who can do, who should be able to do. And so I really understand that, and that your transcript is not your sum total of your worth. And I think that's helped me identify some absolutely fabulous people who have gone on and now have gotten NIH grants. And that's I think how Alan and I very much try to judge who's going to come and work on the study and where they are in their head, and who's also going to give back. Because there's some people who, once they get to the mountaintop, they're not going to reach back and pull somebody up. And if we get that feeling in the interview, then okay, you may be good, but you're just not that person that we're looking for. Because that's the other way we get people, because people who have gone on say, oh, I saw this student, you should talk to them. Maybe this is somebody you could help and who would be good for the study. That's the other way. We have like a little bit of a chain going.
Mm-hmm. Mm-hmm. Yeah, and so one of the questions in the chat is around cultural competency and how important you think that is for African Americans to seek and to be treated by African American medical providers.
Well, yeah, I am a great believer in cultural proficiency, cultural competency. Alan and I wrote a course in cultural competency for our staff. So before we went into the street, we had, a week-long course that we wrote. We got contractors in, we got professors in to sort of get everybody on the same page. And then every year we have a cultural competency. I don't like to call them trainings. I call them events. So when the African American Museum opened in Baltimore, we had a docent who took us through the entire museum. When the Smithsonian African American Museum opened in Washington, we rented vans and the whole staff, they took the day and we had a docent, we went through the whole thing. My husband went, Alan's wife went. This is important. Everybody needs to be here. And if you wanted to bring your children, yes, we paid for the tickets. Because at that time, not paid, but you have to, when you do these groups, you have to get the big group ticket. They're doing it a little differently now, but it was a hassle in the beginning, but we had a group of like 50 people. And that was something that was just, it was just enormously valuable to start conversations. And cultural competency, if you're Black treating a Black, I have been mistreated by Black physicians because they think that, number one, they don't think that I'm a physician coming in, and they just think they've made it. And I'm just like, well, we're really the same. Why would you? So I think everybody needs cultural competency. Being Black is not a shield against not giving adequate treatment and respect to your patient who may be of the same race.
Right. And I think that's something we all need to sort of think about, is that the sort of white supremacist ideology has infected all of us.
Right. I've made it, so I'm one of them, and I'm not really sure what it is that you're bringing to the table.
Right. So I think that's something that we need to all keep in mind. I think I want to maybe switch gears a little bit and talk about the longitudinal study. So someone's asked about a longitudinal study focused on telomere length between generations and race, but I'm also interested in NIH's sort of view on longitudinal studies. We are sitting in the Deep South. We're sitting in Alabama. Alabama Black Belt is right here. As you know, there are lots of health disparities. There's a lot going on in the Deep South in terms of health. And honestly, I think while the Mississippi Delta gets lots of attention, Appalachia gets lots of attention, the Black Belt is not. And so what's going on with NIH in terms of thinking about what is being experienced in Alabama?
Well, I mean, I think that things have changed and that NIH is much more receptive now to the concept of health disparities research. Initially I had difficulties because I was somebody who, if you look at my early publications, it's on the biochemistry of DNA repair in cancer. And then I just was like, okay, well, I don't know if I could deal with this anymore. And I just decided I wanted to go back to something that was more rooted in my own life experience. And that was a very difficult turning of the USS Enterprise, because they just couldn't understand why I would want to do that. What was valuable about doing that? I said, well, I'm working in Baltimore, and this is what I see on my way to work. And I grew up in the South Bronx. So you know what? I understand what's going on in Baltimore, and we, NIH, should be studying that. And this was before this was back, in the 1990s, 1996, 1997, 1998, there was only the Office of Research on Minority Health at that time. So this was not something that was on NIH's radar screen. But in these last several months, with, I think, the evidence that's staring us all in the face, that NIH's mission is to lengthen life. And well, are we really lengthening life in everybody? I think the answer was clear. And so Francis Collins, has pulled up on that. And, we are making attempts to really focus on how do we intervene, not just admire the health disparities that we know exist, but are we moving towards intervention? And so we have a group called Unite. I'm one of the heads of the new research in health disparities. And one of the things that Dr. Collins has agreed to do is to have a common fund initiative that focuses on interventions in health disparities.
Okay.
And so that's going to be funding that will be out this year, but also a larger initiative in FY23 focused on health disparities, as well as several other initiatives, one looking at structural racism coming out of NIMHD that is actually on the street now, I believe. And then NIGMS is looking at the influence of structural racism in diversity as an impeding factor in diversifying the workforce in biomedical research. So I think finally, maybe we are at least using the same hymnal. I'm not saying we're all singing from the same exact sheet, but we're at least now using the same hymnal because many of us have felt we've been out crying in the wilderness for a bit, but I think COVID just made it clear that no, we were not whiners and complainers. We were not hypersensitive. We were just not working in our own personal interest. We were actually trying to represent what's happening in the United States.
Yeah, yeah. And I think thinking about differences across these different communities too could be something interesting to think about. So what you experienced in Baltimore
is going to be different perhaps than what you're seeing in Alabama, for sure.
Right. And so, but it also made me think too, and when you were presenting your data about the sort of younger group and their perceived racism or discrimination, like impacting health differently than in the older group. And I was wondering if you had thought about differences in across the generations and how they perceive discrimination, right? So I have a 23-year-old who grew up very different than I grew up. And I mean, I sort of taught her about racism, but there's a whole group of them who just don't understand racism. They don't understand discrimination in the same way.
No, and that's true. So, and that's what I did think about when I saw that data. I was like, oh, that's wrong. You know, we always say that's wrong, but then I said, oh no, actually that is, we did it right. Wow. But I have a 25-year-old. So I understand exactly, because we have given them a life that was very different than I had growing up in the South Bronx. It was clear who you were, what you were, and that it was a struggle to climb up out of the projects. I grew up in the projects, you know, she did not. So, it wasn't quite clear to her. It didn't become clear to her, I think, until, the better she did in school, the harder things got. And then she started wondering why it got harder. And yeah, well, I don't know. I said, I'm not sure. What do you mean? And so finally she caught on to it.
Mm-hmm.
Yeah, their experience is different. And some of it is, I'm not sure in terms of the white matter lesion volume, do you have to be a certain age? Is there an age of vulnerability that is just higher? Maybe it's in the late 40s, early 50s, where there's brain vulnerability because of accumulated damage, and that's why we didn't have it. But they also see racism differently, and they experience it differently. And I think they have different coping strategies.
Yeah.
And older people, we don't, I think, look at it that way.
Yeah, yeah. I'm not saying that their coping strategies are effective, because from
right.
they're not effective
right
at all. And not noticing it, I think, for some of them makes it worse.
Mm-hmm.
Yeah. I'm not seeing any other questions pop up, so I'm going to go back to so one just popped up. So what advocacy can those in the community take when they identify disparities in quality access or medical technology?
Yeah, I mean, I think that's a hard one, but I think one thing, most of the major medical centers do have community groups. They actually have an executive whose job it is to establish community relations and maintain them. And, those people shouldn't have an easy time of it. When a problem is noted, they need to be called up on it. And sometimes I think that, the community boards, say, okay, well, they're doing this and this and this, so maybe it's okay. But no, we have to be able to point it out as something that needs intervention. It needs amelioration, because otherwise it will just linger as a problem.
Yeah, and so I guess another question that's kind of related is, so what do you think the importance of having physicians who live in the community on the quality of the healthcare?
Yeah, I do think that, I think that to a certain extent is important. I don't think it's necessary. But I think sometimes to really understand what's going on, for a time I worked in a community health center, and I was living in the Bronx at that time. And I knew that if my patients at this community health center took the bus 5 stops up, that they would be able to get better fruits and vegetables and fresher meat and actually fresh fish. So I went across the street to the place, the supermarket that was across the street from the health center. And I said, you know what? You need to fix this. Otherwise, I'm going to start providing bus tokens for people to take this bus 5 stops up and go shop at that supermarket. And so he called me a bully. Then he told my boss. And I said, well, oh, so you're trying to make money on these 210s over 110 blood pressure that come rolling through the door every day. I said, well, that's not what this community health center is supposed to be about. So as you can imagine, we had a slightly adversarial relationship, but the fruits and vegetables got better. There was more of them. And I started doing my shopping there so that I could keep it. Hey, how you doing? Oh yeah, those apples look great. Oh, but those collard greens, they didn't look so good. And you know what? Why do you have to have so much fat back here? Maybe you should have recipe cards up. Oh, I was very aggressive. But I was aggressive because I lived right there in the Bronx. So I knew what was being purveyed. Mm-hmm. And I could be that squeaky wheel that, he was feeling a little guilty about. And he also knew that I was the type that I would give them bus tokens up to the net and back. And he didn't want to lose those people who were in walking distance.
Mm. Yeah, I think one of the comments or one of the questions is related to this is about living out of state. So having physicians and healthcare facilities from out of state companies come in and out. What are your thoughts about that?
Yeah, I think we want to have the best trained healthcare workers we possibly can have. And some communities, it's going to be difficult to get physicians that want to live and work there. But I do think it should be a requirement of those medical facilities to make sure that they provide a grounding in the community, in the facilities that are available, in what is the resilience of this community? What is this community's SVI? It's the CDC measure. Do you know what the social vulnerability index is of where we're standing right now? In terms of housing, in terms of transportation, even in terms of trying to make appointments for people. If you don't understand what's their transportation need, then you'll say, well, gee, checking your blood pressure tomorrow and the third day, that's going to be a problem. Let me come up with another rubric for you doing it, because it's going to be hard for you to get somebody to drive you or get you here in a time when both the patient and whoever their transporter may be working, and they don't have the type of jobs where, okay, I'll take 2 hours of sick leave and come and do it. A lot of jobs don't have that. So that's where the problem comes in. They just don't really understand the community. But I think it's the job of the health centers, the medical centers, the hospital, to really school their physicians on what are the dynamics of the population that's in this catchment area.
Yeah, yeah. And then I think one of the, maybe we'll begin to wrap up, is really about NIH incentives, right? So NIH does give like funding to some of the big universities and the big medical centers, right? So could there be an incentive for those universities who actually provide primary care physicians to underserved communities, right? So if we take Alabama, for example, there are a number of rural communities, the hospitals are closing, they don't have access to physicians, there's no OB sort of services in many of these rural communities. Can there be some incentive or some preferential treatment for those universities that actually provide those services?
Well, as part of the Common Fund, that's exactly what we did. What is coming out in FY21 actually is two funding opportunities. One is only for minority serving institutions in hopes of providing that opportunity for those more under-resourced environments to be able to compete. And in the FY23 announcement, the committee that's working on that is also considering these issues, because an intervention that may work in New York City may not work in Dothan. It just may not. And why? You know, and the reasons could be very different. So we want to make sure that those who are proposing the interventions are coming from a myriad of communities, not just racially different, but also different in terms of the contextual environment, because geography certainly does influence health disparities. And it's not just rural versus urban. You know, there's lots of complexities to the geography that create these issues.
Yeah. So I think as we begin to wrap it up, I mean, I think some advice to University of Alabama in particular, in terms of supporting our students, since you're the training director at NIA, how can we prepare our students to go work in your lab or the other sort of labs at NIH? But also, like, are there some priorities other than these common fund ones that we as researchers maybe should be thinking about?
Right. Well, I think that's also part of what our Unite group is going to focus on. I think, yes, the Common Fund is only one thing. One of the things we're doing is trying to identify those gaps in health disparities research, in minority health and health equity research that are not being covered by the money that NIH is spending. I think no one is saying that NIH is not spending money on health disparities and minority health research. We're just, our concern is that there are still gap areas that are not being included. There are researchers who are not able to effectively compete in their areas of expertise for R01s and other types of funding. And so those are the kinds of things that we are looking at in terms of as an educational facility. I mean, Alabama turns out a strong student. But I would encourage focusing on, you know, those students who feel that they're at the margins. So many of the students that I invite into my lab are like, well, I'm just so shocked you picked me. Why did you pick me? You know, it's that personal statement that you wrote that lets me know this, you're willing to die on this hill to get this opportunity. And also in those letters of recommendation that you write, they need to point out the potential of the student. And so I and many at NIH are now beginning to understand, well, yeah, that may be a well-earned C. And what's wrong with that? That's not a marker of your potential to contribute or to be a scientist. You know, not all Nobel laureates were straight A students, and we need to remind ourselves of that. And so I think some students count themselves out saying, oh, well, my transcript isn't, I'm not qualified to do that. Yeah, well, we need to erase that from their mind. If they want it, if they're willing to improve, if they're willing to work hard, those are the most important qualities.
Yeah, that's good. Something I kind of wish that we had some undergrads on the call so they could.
You've had those conversations with your students. Yeah. People call it imposter syndrome. It has many names, but if they don't reach out and try, if they count themselves out, they're self-segregating themselves from the opportunity.
Right. Yeah. No, my advice is always don't tell yourself no, let them tell you no.
That thing that you just said, that's it.
Okay, so before I wrap it up, are there any other questions from the group?
I really enjoyed the whole presentation. I'm just floored by the information, and thank you, Dr. Evans, for just giving it all to us at one time. I'm going to digest this, watch the video again and digest it. I saw a question or comment about social vulnerability. Where can we find more information about it? I mean, how do we get our local council persons and medical administrators to see that, hey, overcrowding this particular area is creating a social vulnerability that we don't want in the community?
Right, it's all on the CDC website. If you Google social vulnerability index, the CDC website will come up, and then you can look up by zip code. I mean, it's an interactive map. Yeah, CDC, I mean, they did this right. Yeah.
Okay, and I appreciated you doing the comparison with Tuscaloosa, and we can also get that information at that website as well.
Yes, yes.
Okay. And you can do a zip code comparison to.
Right, you can zip code. So all I did was I looked up the zip codes for Tuscaloosa, and then went and found them on the interactive map for Tuscaloosa.
Right. I think you're gonna get us into some good trouble.
Oh, well, Brother Lewis asked me, just like he asked us all before he left us.
Right.
He told us what to do, and I took him at his word.
Right, and I think this leads into, in your presentation, when you said we have to educate others and get this information in front of the advocates. You got to get in front of those who are making the laws and the rules and the policies. Like you said, structural biases and discrimination and systemic racism and all that kind of stuff. But we have to get this information, and I think it's powerful that they know that we know, right? Yes. So I think that's going to be the key. They have to know that we know and are aware with this information. So like I said, you got us into some good trouble. So you will hear from us, and we will have you back. I'm going to mute my microphone in case anyone else has anything to say. But
well, thank you for inviting me, Chad. I really appreciate it.
You know, always. I'm going to mute again and just see if anyone else has, then we'll close the program officially. Okay, thank you.
Okay.
This is Cassie Simon. I just want to say thank you, Dr. Newman. I look forward to meeting you when COVID allows it. And Dr. Evans, I thoroughly enjoyed healthcare disparities in the area of oncology was my area of study for about 10 years, because I was a breast cancer survivor and got the triple negative at age 36 back in the 90s. So much time has passed since, right? So I'm just real fortunate to be here because they were doing clinical trials then on triple negative. So I knew some foundational information and some stuff about healthcare disparities, but I really enjoyed your presentation and the way you pulled the different aspects of things together and made some things very clear for anybody who had any any awareness whatsoever. It was very clear how you connected all of those things, and I really appreciate that.
Oh, well, thank you very much. It was just a pleasure to interact with you guys. I just wish it could be in person, because the last time I was in Tuscaloosa, I had a great visit.
And we can, I have a presidency for one more year, unless I run again, but we can make that happen. Say less, as a young people. Say less, and we'll be we'll be happy to do that. I think we had a question that just popped in, Dr. Newman.
So while I'm a more sort of basic science researcher, it's always interesting to learn how I can support the translation of clinical findings. More so how these findings are racially and biologically dependent. So not really a question, more of a comment. But I will say we are definitely thinking about a cohort study here focused on individuals in the Black Belt and from a whole sort of lifespan kind of idea. So
sounds like a plan to me. FY23.
Yep. Well,
like
we will be in touch.
Okay.
So I think it's important for us to do.
Yeah, and I don't know Crystal Hill, but Crystal, thank you for participating and listening. And as a basic science researcher, thank you for being interested in how clinical and social, behavioral, political, environmental factors can also influence and impact the work you do. So thank you for participating and listening to Dr. Evans' presentation and the moderation by Dr. Newman. That's encouraging that you were here, and I just wanted to say thank you.
I'm just jumping in here. I appreciate it. I just kind of found it on the internet, and I was like, oh, let me listen to this talk. So I really appreciate you guys putting it together. So thank you.
Yeah, I do want to, while we're giving thanks, I want to take the opportunity to thank our BFSA e-board members that are on the call. We have our Vice President, Dr. Cassandra Simon, who just spoke. We have our Treasurer, Ms. Cynthia Moore, who is here. We have the parliamentarian, who is Ms. Lisa Young, and she's also the newly elected president for NAACP here in Tuscaloosa. So I know she had an audience that's on the Facebook. Again, Dr. Newman, we thank you, all of our BFSA members who joined us on the Zoom and on Facebook Live. So Dr. Evans, we will publish this video again for those who could not attend. We actually will put it on our website as well. And Dr. Newman, thank you, awesome job, awesome job. And again, thank you all so much. This has been very informative and impactful for our communities and as advocates. We need to keep this information in front of us so that we can change lives one at a time. Okay, so we thank you all
very much for inviting me.
Yes. Yeah, any closing remarks or closing statements?
No,
This
just
is a
thank
great
you. I was
presentation.
honored to participate.
Thank you.
Thank you very much. It was great.
And Sharlene, we got Dr. Newman, we have a BFSA meeting tomorrow. 12.
He's trying to get me to be more active.
Oh yeah, we got you included. All right, so thank you all. Dr. Evans, look for an email later from me today. We have a basket that we want to get to you, okay? Since you mentioned apples and fruits and stuff, got something for you, okay? Again, thank you all. Thank everyone. You all have a great day, and thank you for being a part of BFSA.
Thank you.
Bye-bye.
Bye.